had a right eye subtotal retinal detachment with giant tear macular off back in 2008. He received the surgery of buccal and PPV and cryo and silicone oil. And then he did second surgery to remove the cataract and insert the intraocular lens and silicone oil removal 1 year later. And he received the third surgery of the further silicone oil removal both in the anterior chamber and the vitreous cavity in 2014. However, he developed the posteriorly dislocate the PC intraocular lens in 2017, and then he received the fourth surgery to remove the one-piece intraocular lens, and then had received a sclerofixate one-piece PMMA lens, but he had he had subluxated the one-piece PMMA lens this year, and only one haptic was subluxate. So this IOL have the two holes at both haptics. So this is the surgery video, how to fixate the intraocular lens. So we can see there is a broken tenoproline in the one haptic of this IOL. And we first make 2 paracentesis and 3 and 9 o'clock, and then dock the tenoproline 1.5 millimeters posterior to the limbus. And then we pull the end of the tenoproline into the vitreous cavity. And thread the end of the tenoproline inside the hole of the haptic. And because the haptic is not well seen, so I use another serrated forceps to grasp the haptic and then insert the tenoproline inside the hole, and then pull the tenoproline out. And then the haptic was stuck into my forceps. So we need to pay attention to this maneuver because we may have broken the other attached tenoproline. And then the tenoproline was pulled back to the anterior chamber.
Christina.
You did that by manually, Dr. Li King.
Yes, and then the tenoproline was pulled out from the corneal paracentesis. Yes, with the twilight. And then we thread the tenoproline to another tenoproline needles outside the eyeball. And then pull the knots out from the sclera. And then we dock the tenoproline to the sclera 1.5 millimeters posterior to the limbus. And then pull out the end of the tenoproline and tie both ends of the tenoproline. So the intraocular lens position was well intra-op. And after the operation, 1 month, the pinhole visual acuity was 0.5, and the auto-refraction, the cylinder was 2 diopter. The intraocular lens position is good. So this is the end of the video sharing.
Nice surgery. I would like the comments from Adele. Adele, do you like fixating the intraocular lens like that? What technique you use, and what are your comments on Dr. King Lee technique?
So definitely this is very fascinating. Dealing with those very thin threads inside the eye is definitely, it definitely needs a very good hand. So congratulations on a job very well done. I would say that personally, when I do use sutures in suturing IOLs, I tend to like to use the Gore-Tex sutures. The reason I do that is because I have a little bit more control. They have a little bit more memory in terms of how we can manipulate them inside the eye. I have personally tried it with through the loop in one of those PMMA's lens, but definitely could not do it into the vitreous cavity like you were working in the case you showed. I tried to bring it into the anterior chamber and work over there. But fascinating. Congratulations on a very nice technique.
Well, I think the tenopoline is very thin, so it's easier to thread in the hole. So, what's the size of the Gore-Tex suture? Is it the size of 5.0 or?
Have, no, we have 8.0. This was the one I was using. So it could go through. It was definitely a little bit bigger, so a little bit challenging to go through, but it could go through the opening. Again, it's much more challenging using the Prolene in terms of then how malleable it is, especially inside the vitreous cavity.
Yes. So how would you manage if the intraocular lens was totally dislocated into the eyes with the intact capsular bag? So how would you manage to do the surgery if it's totally subluxated? Yes.
So personally, especially if it's a single piece IOL, I would tend to remove it if out of the eye and place my new IOL. I know sometimes you have a very challenging case where you have a kind of an eye that was, let's say, post-VRK, or you know that this measurement was really difficult to get, and you're not very sure what's the size of the IOL, so you want to keep the IOL as much as you can. But personally, I'd rather remove it, deal with it if I can at the same time. And if I can't, and I want to be very sure, maybe I can do the calculation and implant the IOL in another setting, if that's possible.
Very nice, and great surgery again, Dr. King Lee. Very well performed, and you've got a very good technique. And of course, it's good to do with this type of illumination. Otherwise, we could not see well the fundus, and this was really cool. And would like to comment on that case, Athanasius. How do you like using, the secondary intraocular lens fixation? You are muted, Athanasius. Your microphone is closed.
Yeah, okay. First of all, I would like to congratulate the technique. It shows a lot of dexterity that is not applicable to all of us. So if a system that you can just easily done by somebody else, I don't think this is an issue for this case. It's not for everybody, this kind of technique. It's for very delicate maneuvers. On the other hand, I would rather do the Iki Ahmed technique of suturing the haptic on the iris directly and hold it there. And that's much easier and much more applicable to most of the surgeons. But congratulations again, this is a great idea.
Thank you.
Yeah, thanks. And we still have time because we did such a nice schedule over here, and we still have more. We could go with 2 more comments on the technique.
May I ask something?
Sure.
To the colleague?
Yes.
do you, for the intraocular manipulations, do you also use a 4-port, a chandelier light, in order to have both eyes free to do the manipulations?
Yes, I use the twilight or the chandelier, and I use both hands to do the maneuver. I use 2 serrated forceps to help to thread the suture inside the hole.
Yeah, very nice. Very nice. Congratulations on your technique. Very nice technique.
Thank you.
Olivia from Bolivia, and how do you like here if we compare to South America techniques? How do you compare this technique, Olivia, to ours, and would you do anything different?
Yes, I want to congratulate King Lee. It's a beautiful technique. I used to do a Yamane technique. In these cases, I would probably take out that lens and do a Yamane technique. It's my favorite, and on my hands, I have better results.
All right, Sasamoto, do you like the technique?
I love the technique. Sometimes one of the problems is the tilt of the lens, with this technique, but it was really very good technique, Dr. Lee.
Yes, thank you.
All right, and before we thank you very much, Dr. King Lee, and we started with you because you are a bit further in your time.
Yeah.
It's now 9:16 here in Brazil and 8:16 p.m. for you in Hong Kong.
Yeah.
So it's so good to be with you overseas like that, and even virtual. We appreciate your technique. And before calling for the next speech, that according to the program here, we will start with Latam #1 societies. But before we call them, I would like to introduce you André Jucá from Brazil. He's been participating with us since the first Retinawesome, and André Jucá is a very good guy, a friend of us, and we were friends and very friends with Dr. Jorge Mitri that passed away like some months ago, and we felt that so much because Jorge Mitri was with us in many of our meetings as well, and André Jucá is a very good guy, and I'm happy to tell him that because André Jucá, he studied in the Cansvan in France, and now I'm going to be there too at the French Academy of Surgery, and to be involved with the team over there. And André Jucá is invited to go back there sometime so that we interact, and he's my next guest for the French Academy of Surgery. André, ça va bien avec toi?
Très bien, merci. It's always a pleasure to be here in Retinawesome with all your team and all over the world. And very nice case. Congratulations.
Very good. And now I want to start the Latino American Societies #1 here. Of course, we're going to mix in between with other societies, though, so because of time constraints and the different times all over the world. And now it's exactly 9:20 or 1 minute to go. We have some free time to discuss more cases, and this new design help us to interact more, discuss each other's cases, and put our ideas, and this is very interesting. And from Latam, in the Sociedade Boliviana de Retina, #1 on vitreoretinal surgery, I want to introduce you as the keynote speaker, my good friend, Dr. Marcelo Murilo Sasamoto. Thanks, Marcelo. Muchas gracias.
Thank you. Muchas gracias, Hudson. I'm gonna share my.
Interesting facts about Bolivia is that the first interesting fact that I've told you is that my father was born in Bolivia, and he immigrated to Brazil many, many years ago, and he was the introductor. He was the founder of martial arts here in Brazil. And the same city, Santa Cruz, has Olivia Valdivieso. It's so nice to be with you guys over here because we are brothers and neighbors. And Marcelo lives in Santa Cruz.
La Paz, La Paz.
La Paz. La Paz. How far is La Paz from Santa Cruz?
By plane is just 1 hour, and by car is probably 10 hours.
And the interesting fact is that Bolivia, La Paz, and Bolivia in general, is a very high country in altitude. So he's always in shape because he's just jogging here and doing pilates and running, and that keeps you in shape. And some people from the soccer team everywhere in the world, when they're gonna play elsewhere, they like going to Bolivia to get more air, more lung capacity. This is very interesting that we know about Bolivia. Now, okay, Marcelo, if you wanna start your video.
Yeah, everything is okay. So I'm going to start. Coincidentally, I'm going to talk about scleral fixation in retinal pathologies. I have 3 cases. The number 1 is IOL fixation in a 10-year-old patient. The thing with the first case is this is a 10-year-old girl who underwent congenital cataract surgery at another center. When she was 8 years old, she had an inflammatory reaction secondary to lens placement. So it creates an anterior and posterior synechiae, an inflammatory membrane also. The lens, as you will see in the video, is going to be removed, removing obviously the inflammatory membrane, releasing the posterior synechiae, and in the posterior pole, we have an epiretinal membrane removed because of the inflammation. Also, this patient had an elevated intraocular pressure. We put an AMET valve FP7 due to ocular hypertension. We use triamcinolone a lot in these cases, inflammatory cases. So we finished with triamcinolone in posterior and anterior segment. There is no toxicity like some of some colleagues mentioned. There's no, I never see toxicity because of triamcinolone. Then 1 month later, we performed the second surgery. We put a 3-piece intraocular lens transscleral fixation. Sorry. Due to manipulation.
Marcelo,
yes.
why did the iris got this color, whitish? Why do you think?
Because of manipulation, there's a lot of loss of pigment and atrophy. No, mm-hmm. So that's why the iris went like a different color. And as you can see, they performed the first surgery that was in another center. They performed extracapsular surgery. No, probably they got some iris removal or movement, and the pigment was lost. So the first surgery was that, and we performed the second surgery extracting the PMMA intraocular lens. So there's a lot of surgeries underwent in this eye. So that's probably the iris atrophy.
Okay.
So we performed the transscleral fixation in this lens. As you can see, the cornea is probably 2 years. I had to mention that 2 years after this transscleral fixation, the patient underwent a corneal transplant surgery, because of the surgeries and everything. Now it's very good, but we needed to put the fixation to prepare this patient for this corneal transplant surgery. As you can see, we performed the scleral pockets, And I love to do the Agarwal technique. This is a second surgery. The second surgery is a case of a single eye, blunt ocular trauma patient with a PMMA lens in the posterior pole. Due to the narrowness of the pupil, we perform a pupillectomy with a vitrector, removal of the PMMA lens in the posterior pole. You will see. And once we remove the PMMA, we perform a vitrectomy. One of the optics is removing the PMMA. One of the optics of the lens stayed in the vitreous base, so we needed to remove it. Here's the posterior pole. Here, there is one of the optics near to the vitreous base. We perform a very neat vitrectomy, remove the optic, and then we see there was a tear secondary to trauma. We perform laser. 1 month later, we put a 3-piece IOL, a transscleral lens fixation. We create the scleral pockets and also create a tunnel in the scleral edge of the pocket, so the optic enters and is buried, and then the scleral pocket is closed with Vicryl 8O. It's very important to close adequately these structures to avoid the extrusion of the optic. We close also conjunctiva and finish the procedure. So I prefer to do it 1 month later always to avoid inflammation and complications due to inflammation, choroidals, and that's why 1 month it's a good time. Also, you can see also the iris atrophy because it was extracapsular performed before. And this is a patient that I like to show always. Is an Rob patient. In 2015, I performed vitrectomy because of a retinal detachment. This is a video of 2015. We performed our lensectomy. Then, actually, the first surgery was the retinal detachment. You can see all the procedure, but the thing is, with this patient, the first surgery was thought to have removed all the posterior hyaloid. However, it is very common that after a few weeks, the remaining posterior hyaloid appears again, exerts traction again. So this is the second surgery, 15 days later. As you can see, there's a contracture of the posterior hyaloid. It's like it's a lot of traction with the. So this is a common problem with the pediatric retina detachments, the hyaloid, the posterior hyaloid. So we start to removing all the membranes. One thing that is very important is to use a lot of stains. In this case, we use triamcinolone and try to remove it all the posterior hyaloid possible. And in this, we put some laser, but the second surgery was done. We put some silicone oil. Then we remove it 3-4 months later, the silicone oil, and that's the retina attached. 5 years later, we performed the transscleral fixation when the patient was like 5-year-old, and we perform. One of the things of the conjunctiva and the tenon is that they are edematize very quickly the tenon, so sometimes it's very hard to perform these scleral pockets. We are performing that. At the moment of the transscleral fixation, a great care must be taken to cover the optic in the best possible way, since the lens must last as long as possible. No? We don't know the future of this surgery. Actually, no one knows, but we need to be extremely careful covering the optics and doing good work as long as possible. We work with 3D, as I mentioned, Hackstride microscope, Worldly platform, and that's the way all my surgeries goes. And now the patient is doing well, and that's my case. Thank you very much.
Congratulations, Sasamoto. Nice cases. Really good. And,
Thank you.
We've been doing different techniques elsewhere in the world. We have so much influence from many countries. And recently, I know that André Jucá, and I would like him to comment on our case. He does a very nice, interesting technique that recently was chosen maybe one of the best in the world. André Jucá, could you comment on Sasamoto's cases?
Andre, I saw your videos of your technique. That's an awesome technique.
Very nice case. Pediatric patients, they are always much harder. So congratulations for the case. But I have a question to ask. The position of the intraocular lens in these pediatric patients is different, and the size and the power of the lens. What about that? Any adjustment that you do differently from adult patients?
In pediatric patients, we put it hyperopic, so in the future it would be a metropic, but that's one of the things. The other, I prefer to perform this technique when the pediatric patient is like 3 to 5 years, to better manipulation of the eye. I think that's one of the differences with a conventional technique. Then we need to avoid, we need to be very careful with putting the optics in a good position to avoid tilting. And because they are kids, we have to be extremely careful, the parents especially, because of any traumatic problem, any problem like that. I have one case that the intraocular lens went to the posterior pole, and I need to perform the same technique. It was a kid, and one of the things is that I need to be ensure that the optics need to be again re-put, and one of the things is that sometimes in a second movement, the first technique, it doesn't go that well. So we need to, in my hands, I need to change a second technique. So I use a Yamane technique when I have some problems or traumatic problems with these patients. So the first one is Agarwal technique. If I have any problem that the intraocular lens went to the posterior pole, I use Yamane, not to avoid problems.
Okay, thank you.
May I also ask a question?
Sure.
In cases of when you have a secondary IOL implantation where the lens is not in the capsular bag and you have to give silicone oil, how do you assess the risk of silicone oil migrating to the anterior chamber? And do you perform a surgical endarterectomy?
Well, it's a very good thing to have an intraocular lens. I mean, to fixate intraocular lens when you have a silicone oil to avoid that problem, to avoid the silicone oil anterior chamber. But I think the technique for me is 2 steps. No, number 1 is attach the retina, put the silicone oil, and wait 15 days or at least a month to perform the second technique. Sometimes it's difficult, but I prefer to avoid inflammations and to reduce the operation time. So I do it in 2 steps.
But if you need to perform when you have the secondary IOL implantation and you have to give oil, would you perform a surgical endarterectomy to reduce the risk of silicone oil migrating to the anterior chamber, or you don't see any danger?
You mean putting the intraocular lens or performing the?
When you have
Okay.
you have performed the surgery for the secondary IOL implantation, and then afterwards, some days or some months, if the patient has retina detachment, would you perform a surgical endarterectomy, or you don't assess the danger of silicone oil migrating to the anterior chamber not so high?
No, it's not so high.
It's not so high. Okay. Okay. Thank you.
May I say something?
Sure, go ahead, Athanasius.
Yes. The thing about endarterectomy that was invented in order not to raise the pressure of the eye, not to remove the silicone in the anterior chamber. The endarterectomy purpose was made because we had overpressurized eye with silicone oil, and we cannot have a 12 o'clock iridectomy. So Ando brilliantly said, I'm going to do a 6 o'clock, and this way the fluid was going underneath, and it was calculating the intraocular pressure. So it's much more for the intraocular pressure than for the preventance of anterior silicone. The second issue is if you do the endarterectomy in an eye filled with silicone oil, as a second step to go and do that, the suction of the vitrectomy while doing the endarterectomy can be like that it's going to make a less pressure in the anterior chamber for a minute, and then the endarterectomy will be an issue because through the endo it's going to be silicone oil in the anterior chamber. So it's not a very simple technique to do an endarterectomy in a filled silicone oil already. You should do that before getting the silicone oil inside the eye.
That's true.
And it's not going to prevent that anterior chamber filling with silicone oil. Unfortunately, I used to do surgery before the endarterectomy, and we have huge problem with the sorry to say that because that means that I'm old, but there are many other ways of doing that. But thank you very much for showing that problem, because in children with silicone oil and all that stuff, this is not for every surgeon. This is specially done, and it's beautifully done in your presentation, as you should do, respecting the eye and respecting the inflammation. As for my friends, this is my experience, and it doesn't apply to everybody else. Okay, thank you.
Thank you, Athanasius.
Thanks, Sasamoto. Loved your cases. Congratulations. And you are really retinawesome, as I say. And I would like to invite our good friend here, Alejandro Holguin. Alejandro Holguin, it's your first time in Retinawesome, so it's really a pleasure that you are here representing the LATAM and the Sociedad Boliviana de Retina. For us, it's a great pleasure because we want to get involved with our societies over here as well. And so it's a great honor to have here for the first time. Could you, before you presenting your case, could you tell a little more about your service And where is your practice?
Yes, hi everyone. Thank you for the invitation. I live at Cochabamba. It's right in the middle of the country between Santa Cruz and La Paz. And mainly we work here in a private practice, but we also have a social program that works with the public hospitals in the city. Unfortunately, our public health system isn't very good, so we have to do many things else, as Marcelo and Olivia surely do, to help people with many needs. Mainly, I focus on retina surgery, and we can hopefully have help more patients during the day.
All right. And if you want me to share your video, I'll be happy to do that.
Yeah. Yes, please.
The video that I just got from you. Just a second. Let me just. Thanks for sending. It's a pretty nice one. That's it.
Okay, thank you. So I have a patient had a retinal detachment that was operated in another institution. A sclerobuckle was done a year ago and it redetached, so it was a vitrectomy and silicone oil, and then a phaco because the visual acuity didn't improve. The visual acuity at the moment was hand motion. Thank you. And as we can see, there's the silicone oil starting to emulsify on the anterior chamber. So unfortunately, when we got into the posterior pole, we could see that a PFCL bubble was left on the macula, and also under the retina, there was also a big hole due to the traction of a VRP membrane over the macula. We saw that there was a fibrosis, a subretinal cord inferiorly, and also a VRP membrane over the macula. So we had to take it off, obviously, to flatten the retina. And the hole that was made on the temporal side of the macula was really close to the fovea, so that would be a problem. The inferior retina was rigid. The main lesion borders were already folded, so I decided to do an inferior retinectomy. I started with the endodiathermy. I prefer to do it continuously. So instead of dots, there could be bleeding, but it would be as minimal as possible. I tried to put a PFCO bubble over the macula, but with the risk that it could go under due to the hole that it was there. But I also had to go beneath the retina to take out the retinal cord. So I started with the retinectomy, and of course a little bit of PFCO went under the retina. I managed to get it off with quite easily, and there was a little bit of bleeding, and it got stuck to the cord, so it was actually easier, so I could pull it off with a clot in the subretinal cord. And once I did that, I used the OCT that we can have on our. Unfortunately, we have it on our microscope, and I saw that there was a little bit of traction over the macula, but the superior and inferior borders were the retina was really attached. So I did a limiterexis. Normally, this is we can manage it easier with a PFCL under PFCL, but actually in this case it was quite attached to the retina. It was quite glued, I guess, because of the BRP. There was quite a long time with the problem, and then I proceeded to do the laser. Normally, I do 2 or 3 lines over the retinectomy border. I realized that I made a 180 degrees retinectomy, but I had to do it maybe about 210 degrees because it etched a little bit better. And then I did fluid air exchange. As we all know, we have to be very, very careful with leaving the borders dry at the retinectomy, so no fluid goes under the retina. And this was actually the trickiest part, because due to the hole that was on the macula practically, I had to make sure that no fluid went under the retina. And I finished with a silicone oil injection, but I auto sabotaged myself because I left a lot of bubbles of air, so I couldn't see very good, but we can see that the retina was attached at the end of the surgery.
Congratulations, great case. And we'd like comments from our good friend Jorge Rocha. Jorge Rocha, our friend here in Brazil, from the Brazilian Virtual Retinal Society. It's a pleasure to have you here, and also we thank you for your great participations into the World Retinal Congresses. And Jorge, good to see you, man. And we've been quite busy those days here in Brazil because of the elections and politics, but still we have to wait to forget these things a bit and to talk about the retina. And thanks for coming. Could you discuss Dr. Olguin's case?
Hi, everyone. Thank you to invite me, my friend. It's good to see so many good friends like Nataranjan, Ahmed Salam, Dr. Olivia, and Dr. Athanasius, and many others. It's good to see everyone. And it's a very good case. It's my talk. I'm gonna say something about PVR. And nowadays, perform surgery in PVR is something that's very tricky because we have to peel as much we can the membranes, but when you have short retina, you have to cut. But you can't be economic. You have to do enough, and have to be very careful with PFO to get overneath the retina. And sometimes I'm trying doing the retinectomy on the air, as some guys are preconized. But you did a very good job, and we should clean very much the anterior retina. This anterior retina, that's if you left behind, you're gonna go fibrosis and can detach the ciliary body and make hypotony. But it's very good. Congratulations.
Thanks a lot. And anybody would like to comment on a little more on Olguin's case? It's difficult to do PVRs. PVRs, as Dr. Jorge Rocha just said, sometimes you have to do retinotomies, and if you don't do enough, it wouldn't attach because the retina is already very shortened. And so you have to do the best on anatomy. And your case that you showed is a very tough one and very good. And of course, some PFOs, and you did very good ILM peeling under PFO. I like to do that too, because PFO actually helps you to stabilize the ILM so you can move it freely around the fovea. It was a very good peel. And I think these bubbles at the end of the case, and sometimes we get them, and it's a question of time. They're going to just be less hazy, and they would coalesce and come to a unique bubble, and your case is ready for silicone oil removal in a few months. And congratulations again.
Yes. Hopefully, thank you. The main problem with this is I could put laser on the anterior border of the hole, but due to the proximity of the hole to the fovea, actually I didn't put laser on the posterior border of the hole because, I mean, the scars could expand and then get really close to the fovea. But at the moment, the retina is attached. Thank you.
All right.
My problem on these cases is that you don't know how much peeling you have to do before doing the retinotomy. Because if you don't do enough peeling before doing the retinotomy, when you make a short retinotomy, like the one you did, you had to do a very close to the, away from the anterior chamber, from the anterior border. If you can do it, and you have kept a lot of membranes down there, they're going to be shortened much more. And problems with this in many cases, but in your case, that was one-way street for you. Whatever you did was exactly the same. But I tried to do the same things multiple times. But if the membranes are insisting, and there are multiple membranes, then I got a result of a very shortened retina due to the membrane that I left because I couldn't remove them. Does anybody has the same problem of not being able to remove all the retina, all the membranes?
Yeah.
Thanks a lot. And now moving forward, I want to invite our presenter that I met him in Hamburg. Actually, I was going to the, as I said, the eye bank of Hamburg, because we here in Brazil, we work in Goiânia, our city, with the eye bank of Goiânia, Goiás, the state. And so it's not only an eye bank, it's eye bank, and we have multiple specialties in the ophthalmology, retina, glaucoma, and all specialties. And I wanted to actually see how the eye bank worked there, and I met Dr. Olaf, and he said, no, this Dr. Skivas is here. He's a very nice retina surgeon. And I went to talk to Dr. Skivas, and it's a great honor to invite Dr. Skivas as the keynote speaker for the Retinawesome session now. That he's going to be followed after his presentation by Dr. Athanasius and Dr. Natarajan as well. So please, Dr. Skivas, if you could introduce yourself, and then I will share your video.
Mr. Nakamura, thank you very much for inviting me here. Hello, everybody. My name is Christos Kevas. I'm a VR surgeon at the University Clinic Eppendorf in Hamburg, where I work and live here for the past 17 years. I have the honor of presenting a surgical method that I had developed the last 3 years. It has to do with complicated retinal cases where the complicated part is not the retinal part, but the anterior chamber part. The idea started about a few years ago, where I had a simple case of vitrectomy, but the cornea was relatively opacified. And I started with an abrasure. It didn't make any difference. And then I had the idea, what can I do? I put more viscoelasticum on the cornea, and it didn't really help. Then what I've done, I had the idea of putting a normal soft contact lens on the cornea. And for a reason that I cannot explain, it helped. So a few years later, I had a retinal case it was a patient where he had multiple corneal graft rejections, a completely opacified anterior chamber, and he presented himself with signs of retinal detachment. We verified that with ultrasonography, and due to the fact that it was his last eye, the other eye was enucleated due to secondary glaucoma, we decided for surgery. The plan for surgery was to use an Eckhart keratoprosthesis to remove the cornea, the opacified cornea graft, place an Eckhart keratoprosthesis, do the retina VR surgery, and then put the new graft. Mr. Nakamura, you can start the video if you want.
Sure, and I will share your screen. And then I would like, by the end of your case, a comment also from Dr. Natarajan, who's going to participate, because they have these keratoprostheses made in India as well, very interesting one. So let me start your video.
Exactly. This is the patient. He was 80 years old at that time. As you can see, he has a corneal graft which is completely rejected and is completely opacified. We started the surgery, 3-port plasma vitrectomy. We're trying to stabilize the Eckhart keratoprosthesis, but it's not possible because the eye is smaller. It had many surgeries. The recipient bed was also very thin, and it just didn't fit. We were about to quit because it wasn't possible to stabilize the Eckhart keratoprosthesis. And then I got the idea that I had a few years ago due to the fact that it's his last eye, why don't we place a normal soft contact lens on the eye and try to perform surgery? This is the same idea as a Eckhart keratoprothesis, but I thought it would work. And you see, these are the steps where we try to stabilize the Eckhart keratoprothesis, and it's not possible. So that's a soft contact lens. It's a sterile, soft, normal contact lens that we have in surgery. And we put a lot of viscoelasticum. And what is very important is to stabilize the keratoprosthesis with sutures. What we did, we stabilized it with 8 sutures. You can use Vicryl, you can use resorbable, non-resorbable. The thing is, it has to be stabilized. It has to be stable enough so that you don't have any leakage during the vitrectomy. The viewing of the retina was very good, and we were able to do a PFCL silicone oil exchange, do laser, and at the end of the surgery, we remove the contact lens and proceed with the corneal graft. So the most important step was to stabilize the contact lens so that you don't have any leakage during the vitrectomy, use a lot of viscoelasticum, and the visualization of the retina is more than enough so that you can perform also complicated cases. You can do exchange of PFCL silicone oil without any problems. And we performed until now 6 cases. At the time of this case, it was the 3rd case where we also published it. But until now, we have performed 6 cases, also with gas and silicone oil. Until now, we didn't have any intraoperative complications like an expulsive bleeding. And the visualization is pretty good. So you see now, these are the steps where we fixate the contact lens. In this case, it's a non-resolvable suture, but you can also use resolvable sutures. Most important thing is that the contact lens is stable and use a lot of viscoelasticum.
That black and white was just an effect that I added. Excuse us, just an effect.
It's advisable to start with the sutures at 12, 6, 3, and 9 o'clock, and then go to the other quadrants. You can do 8 sutures or 6 sutures, but I think it's more advisable to use 8 sutures so that the contact lens is more firmly fixated on the globe. This is another case of patient where we thought he had a retinal detachment, but he only had peripheral hyaloid tractions. He was a patient also with retinal ischemia, where we also performed laser, and also the technique performed very well. So very stable, no leakage. The IOD was stable during surgery. Most important, the visualization was very good.
You got a very good view from the periphery.
That's true. That's true. And we also had in a few cases also the nurse is also helping us with the peripheral visualization, and that means she's also you hear me?
Scleral depression.
Yeah, I'm sorry, the scleral depression, and we also had during scleral depression no leakages. But in most cases, you don't need it because the visualization is very nice. And this is the end of surgery where the contact lens is removed, the sutures are removed, and then we place the corneal graft.
How long do you take for the whole thing, for the whole surgery, including the contact lenses and the vitrectomy?
This was about 60 minute surgery. 65 minutes surgery.
Very nice made, and it's amazing to see how you do that, and it's good to have the support from the eye bank as well, and because maybe in some states and here in Brazil it's such a large country, and we have some spots, some states that have their eye banks, and including the capital Brasilia, São Paulo, mostly Sorocaba, and some states, but it's not easy, and the line for the regular transplantations and corneal transplantations, it takes a while, so it's easy to be affiliated to the eye bank. Congratulations again. And
Thank you.
André would like to ask a question?
Yeah, any tricks about the contact lens, any diopter?
No, it's just a normal soft contact lens.
No diopter.
Nothing. It's only a soft contact lens. Nothing. No diopters. Nothing.
Okay.
One size fits all.
Okay. Just another question. Do you have any leakage during the procedure?
You have to be a little bit careful how you put the IOP. We performed surgery between 30 and 50. We didn't have any leakages.
15?
30 and 50.
Okay.
And we didn't have any leakages. But you have to use viscoelasticum. Sometimes I put viscoelasticum between the eye and underneath the soft contact lens, and it seals also the operating field.
Okay. Another question. Do you still use regular temporary ceratoprothes to perform surgery, or just do contact lens?
This is not the cases that we have every day, but due to the fact that I performed them 6 times and it worked, I have a normal Eckhart keratoprosthesis in surgery, but I also only use this case. So that means in the next case, if I have this case, I will only use the soft contact lens. If it doesn't work, and I will use the Eckhart.
Okay.
Congratulations.
Thank you very much. Very nice idea.
Question?
Congratulations. That's
Thank you.
a breakthrough.
Thank you very much.
That's it. And I would like to ask Natarajan, I know that in India you have this India-made keratoprosthesis. Do you have any comments on that? I know that you've shown some cases in the past from some nice techniques. Could you tell us about that? If you are not in now, maybe you are around, I would like to ask Athanasius. Athanasius, could you join us with your case? And after your case, I will invite Natarajan.
Okay.
Do you want me to share, or could you share yourself?
I will try to share.
Okay.
Share screen here. Let me see if I can get there. Well, it has a. Is it applicable to you? I have opened the share screen, as usually. There are some signs here. Do you see what I see?
No.
No, not yet.
Allow zoom, open system president, allow zoom.
I have it here. If you want, I can.
Okay, please, but I need to work with my laptop, and that's why I'm trying to security and privacy. This thing happened to me always in your meetings, that they don't allow me to share the screen. I have some system here that doesn't work.
Yeah, not a problem.
Okay, can you open it from your side?
Sure.
Can you see the screen? Okay.
Already doing that. Let me just. Okay. Can you see it?
Well, I don't know if I'm seeing my screen or your screen. Yes, I'm seeing your screen. Yes.
Yep. You just tell me when to go further or back, okay?
Well, this is an issue now. That's what I wanted to avoid. I wanted to control it myself because that's very important for my presentation. Can I try to share screen again?
Sure. Let me just, you want me to stop sharing for a moment?
Yes, for a moment, stop sharing because I need to.
If not, I'm your hand here, you know.
Yeah, you're always my hand everywhere. It says this will stop other screen sharing, continue. Whiteboard,
maybe.
iPhone,
Is there-
iPhone, desktop one.
Yeah, we are no
it's
longer
showing me
sharing over here, and let me see if anybody is sharing. I think, is there anybody sharing the videos?
Allow Zoom to screen. Allow Zoom. That's what it puts. I'm allowing whom to share. All participants. All participants. A lot of questions to be asked. And location, context general, file, security, and privacy. That's the problem. It doesn't allow me to make changes. It says,
So let me share for you. There's not a problem.
okay, we'll do that way, and I'm still getting angry with this system because something is going on with me. Whenever I get in, something proves me that I'm illiterate when it comes to computering. Okay, you share screen with me.
Sure. It is always an honor to share and to take pictures from you in the Retina. I took some pictures from you. You were awesome.
Okay. Can you start the presentation? Before that, I would like something to say about the Dr. Skeva's presentation. It was simple things are incredible ingenuity behind them because he found the problem and he solved it in the most easy way. Of course, he has a bank behind his back, but this is what they give you in Hamburg. First of all, by coming to Hamburg, you met so many people and you did something else. And the second thing is, I really enjoy seeing that, and I would like to, this way, like a billiard, I would like to ask Dr. Skevas to come to Thessaloniki TVRS, Thessaloniki and summer school this July to teach us a few things and tips and tricks about this, because that's the school about it, tricks and tips all the way. And last, I would like to call the Retinawesome during this time as a world Retinawesome now. It's not a simple Retinawesome like you used to do. This is a world Retinawesome. This is for everybody and everywhere. So try to change the name to World Retinawesome at 18.
Yeah, we are going to do that, and we are present in the
World Retinawesome 1.
Yeah, that's
it's
it.
For everybody, for everywhere in the world. We have a lot of followers now. So let me go to the next step. My problem is that the most demanding eye surgery is combined traction and rhematogenous mobile retinal detachment in diabetic patients. This is very great problem for every one of us. Very often these patients are one-eye patients and they need to see the next day. So what is the issue that I'm trying to apply to you? This is that we have, next slide please. Next. We have to have a patient that would be able to see, and using the normal way of doing that by injecting air at the end of the operation might have some hazardous thing. And I would like to say, how about the use of silicone oil 5700 in these days has changed a little bit the stage. At the end of the operation, usually some heterogenic tears in detached retina, and you have a rebleeding and hypotony at the end of the operation or the next day. Next. When you make an air fluid exchange at the end and leave the eye like that, the advantage is that if successful, it's one surgical procedure, but remember, hypotony and rebleeding, it's a very high percentage. And a patient take time, 40 days, 30 days, 20 days to see, and they cannot perform laser if you have any problem. So you don't have time to change anything if something is going wrong inside the eye. Next slide, please. But using at the end of an operation like that, 5,700 silicone oil, the new one, patient can see the next day. And you have a much better intraocular pressure control under silicone oil, and it's easier to maintain a flat attached retina. But the most important thing is that you buy time to access a post-op problem like laser or something else you need to do at the end, so you don't destroy everything when the air goes, you don't have a PVR or something like that very, very fast. The disadvantage is you need to learn how to do it, and then you need a second operation to remove the silicone oil, if you need to remove the silicone oil, because in some eyes, we don't remove the silicone oil. The next one. Of course, this is my idea. This is not for everybody. That's why this is my mirror that I have in my theater. And so you have to remember, when somebody's talking about his idea and his method, this is the mirror that we usually have. Next one. As most of you know that you are teachers now in Thessaloniki Vitreoretinal Summer School, we try to catch people with tricks and tips that they cannot find in books and give them the latest of technology in Thessaloniki. This time is going to be in July, so it's between 3 and 7 of July, which is the best time to be in Greece. So this year, we are almost fully booked now, but we'd like for you to come as faculty for this. Next. Can you start the video, please? Well, this is a little old technique that we used to do, is to put, without a trocar, to put a second chandelier light in the eye. It's a bit old video, but it shows exactly what I want to show you. And this is a traction detachment, a combined traction detachment in a diabetic with one eye patient who is a doctor in our city. And he has this traction over the macula that destroyed his eye. And we need to remove this. One issue is that we're using 25-27 gauge for this case, so we use the manual surgery all the time in order to be able to lift the membrane and to see what's going on underneath, where are the anchor points, and to cut the anchor points not on the side of the retina, but to cut the anchor points under the side of the membrane. This is the method we're using now. So the other issue that we have to remember is that membranes on the surface of the macula or in a detached retina, they have different dynamics. So you have to know which way the dynamics go. For example, now we are cutting towards the 5 o'clock, but the traction, because of the membrane continuity, goes to 3 o'clock or to 8 o'clock. So that's why you have to have a very wide field of view, not to have a 30 degree. You need to have a wide field of view to see when you're cutting in one place, what is happening to the other areas. And you have to change the forces dynamic by removing the traction left and right of the traction that you're removing now. So you have, if you don't do that, the pulling of this in order to cut the 6 o'clock membrane is going to be a 3 o'clock tear or a 7 o'clock tear. Because now you see how we cut one from the other, and you can see here how delicately the small gauge can go underneath and try to locate where to cut. Under a very nice viewing system, we got the ABUS here doing the ABUS 2 viewing system, the XL. Another place is that we can remove the clots at the end. And then we inject silicone oil in order to have all the benefits that I told you before, to have an eye fixed, stable, no subretinal hemorrhage again, and everything. But during the exchange of silicone oil, as you're going to show now, I don't know why it's not continuing. It's just doesn't show a lot. The video doesn't play. Can you see why? Okay, now we inject the silicone oil with this system, but it's going very slow. I don't know why. And it's jumping. Okay, let's go a little further down. Another thing that we can do while injecting the silicone oil, there's some transfer of pressure it's becoming lower in the eye, and you have a rebleeding from the underneath the cutting vessels. So what are you going to do with the rebleeding of when you have silicone oil already injected in the eye? In the alcohol machine that we're having there, we have the extrusion needle, which is very, very useful in this case, is the extrusion system for the Constellation. So we put it while you're finishing the injection of silicone oil, and you see this is the finalization of the injection when it goes towards the lens, and you can see it disappearing. You can see the bleeding underneath. And then you go with an extrusion fluid needle, you put it on 150 vacuum, you press the pedal, and you can remove the cloth behind the silicone oil. So you have another trick and tip to remove subretinal, and that's at the end. You don't have to suture. It's just because of the small gauge technique, and that's the end of the operation. Next one, please. Next one. Next one. Well, this is thank you in Greece. Thank you very much for accepting me, and looking forward to see you all again. In Thessaloniki, of course.
Congratulations, Athanasius. Great cases, great teaching. It's always good to see how you peel that membrane from this viewpoint of the membrane itself, as you said. So you have to look at the membrane and try to get a cleavage plane. And when you say you have to be in the standpoint of the membrane, what do you really mean? We have to be extra careful not to pull it too forcefully, not to tear the retina down below. And what is your advice on that?
There are multiple forces. The membrane that you're pulling through towards 6 o'clock in order to be detached has attachments to 3 o'clock, to 9 o'clock, to every other area, because it's a flat thing over. So you have to cut the tractions elsewhere, because you might pull something at 6 o'clock and you make a hole at 9 o'clock. And that's what the wide angle observation system is. You have to see, while you're pulling up, which are the forces that they're pulling elsewhere of the side you're pulling. You have to avoid making holes. And in cases like these that they have a very heavy laser, it's much easier to make an iatrogenic tear. So it's a very important thing to be able to detect where to cut, and when you're pulling, where else do you pull and cut this traction before you remove the membrane. You have to have only one plane of removing it, not to have multiple planes at the same time, if I make myself understood.
Yeah, of course. Thank you. And anybody would like to comment? Ahmed, how are you doing? All right.
How are you doing?
How is Little Rock? Little Rock is...
It's very good. Actually, I'm in Egypt, visiting family in Egypt. So it's now 3 o'clock in the afternoon.
Good, good. Would you like to comment on the Athanasius case?
Oh yeah, it's a great case. Good to see you, Athanasius.
No, don't continue, please. I would like to tell you, whatever comments you make, I promised you some muzo in Greece. It's depending on your.
I'm not going to comment.
Depending on your comments. Remember that.
Really lovely case. I agree completely with Athanasius. It's very important to find the plane. I find working from posterior to anterior really useful for this, because most of these cases have vitreous, but there's no vitreous over the posterior pole. So I would start by dissecting from the optic nerve out. So what I do is I put the pressure on 60, I go with the forceps on the optic disc, I peel a little bit on the disc. You cannot tear the disc, but you can get bleeding, so that's why I do this. And then after that, I start from there out. So in my hands, this works nicely. And I get less confused with the vitreous and where is the true plane.
All right then. And Natarajan, are you on the spot? Are you around, Natarajan, to present your next case? If
he's
not,
probably in another meeting. He's probably in another meeting.
Natarajan,
He's a multitask person. He does 3 or 4 meetings together.
Yeah, he can join anytime when he comes, and because Natarajan is in multiple places everywhere in the world. I'm amazed how he does that. He's a very good man. But we could start with Latam number 2, and then when Natarajan gets back, he could present his case. And now, moving back to Latam, I would like to introduce you to Dr. Andreas Di Luciano. Andreas Di Luciano and Dr. Olivia Baldivieso. And why don't we start first with Dr. Olivia Baldivieso from Santa Cruz, La Sierra, Bolivia. Good morning, Olivia. Good to see you again.
Hi, good morning.
If you want me to introduce your video, or I can...
Please, you can run it. It's a great pleasure to share with you this morning. Thank you for the invitation.
All right, our honor. So, you run or I run?
You can run it,
okay.
Please.
Sure, I will do that right now.
Today I'm going to talk about a case of a rheumatous retinal detachment in a patient with an active toxoplasmosis.
That's it.
This is a 28-year-old male from Bolivia who presented to my office complaining about 1 month of fluorescence and blurred vision in the right eye. His ophthalmic examination revealed a best-corrected visual acuity of 2400. He has cellular reaction, and in the posterior pole we can see a supranasal tear, and in the posterior pole a creamy white intraretinal lesion adjacent to an atrophic pigmented lesion. The ultrasonography in these cases is very helpful to show us the retinal detachment and the vitritis. We did laboratory tests with elevated toxoplasmosis antibody antigens. The patient was started on a dual oral antimicrobial therapy, and we added the 3rd day prednisone, and on the 7th day we went on a vitrectomy. We did a pars plana vitrectomy 25 gauge system, and here we are in the posterior pole. You can see here in the center the active lesion, and it was next to an old scar. Remember, this is a 40-year male patient. He is phakic, so I was taking care about the lens. Here again we can see the lesion, and in the periphery supranasal we can see the tear. We did a shaving of that vitreous around the tear, and we tried to shave the vitreous base as much as we could. Here in the inferior retina, we have some lattice degeneration. Here I create a posterior drainage retinotomy. Once it was everything clear, and then I did the fluid air exchange using a silicone tip needle. It was careful, and I take long to do the interchange. Then I did laser to my retinotomy to the tear that was more periphery, and I went with the laser through the peripheric lesions to cover all the inferior zone. I put intravitreal clindamycin, and I filled the eye with silicone oil. In this case, it's very important to close the wound sutures. I always, when I use silicone oil, I close with suture. And this is 1 month post-surgical. We can see the patient with the anterior chamber clean, and the retina is supplied. And here we can see an OCT with intraretinal edema. We have an epiretinal membrane, but this is 1 month of post-operative. The patient is doing great. He's 2100. and I think I will wait at least 1 year with the silicone to take out the silicone and do a peeling in the in that membrane. Thank you.
Beautiful, beautiful case and nice pics and nice OCT. We carry the same OCT over here, and the images are amazing. And the retina pics, they speak for themselves. And how long do you usually take the silicone oil out of the eye? How long you wait?
Between 6 months and 1 year.
Okay. And you said
I want to be sure that the infection is not coming. I maintain the patient with the dual antimicrobial therapy during the 6 week and the oral prednisone in a lowering doses.
Yeah, that was very well
Why you
made.
prefer to do the retinotomy instead of perfluorocarbon? Do you have any issues with it?
The truth is that I didn't want to be near to the posterior pole, and I was afraid of touching the lens because the tear was very peripheral. So I feel very comfortable with a little retinotomy that I can control, and I can do laser around it. It goes great for me.
Great. Very nice job. Thank you.
Thank you.
I like that, and how you prepared the area for retinotomy, and the retina was a bit shortened. But you saw your visualization system is so good that you could see the vitreous base very well, and very well recorded. So it's important. I usually tell the fellows, here we are, we have the Gabriel Matos Machado. He's doing the retinal fellowship with me now, and there are others. And thanks for the Eye Bank Foundation and the fellows and the residents for participating with us. And just say hello, Gabriel, to the audience over here, because you've been doing lots of cases like this one from Olivia, and it was pretty well done. And anybody else would like to comment? Jorge.
Hi, Olivia. Very nice to see you. My
Hi.
pleasure. And congratulations. Your surgery was so beautiful, so elegant. And I know it's tough to operate patients that has retinal detachment secondary to the toxoplasmosis or any other uveitis. And one point is have to prepare the patient for surgery if they don't was treated by the antibiotics. I used to start antibiotic before the surgery, and as you said, use steroids before the surgery, and keep this steroid after the surgery for a long time, because this eyes is very hot. I mean, they can get inflammation and goes in PVR and everything. And the other good points that you did, you need to be very economic and to not touch too much in the retina. You did a very good retinotomy, and sometimes I don't do retinotomy, but I do leave more fluid underneath the retina and wait just for more time to reabsorb by RPE pump. And because nowadays the idea is in retinal detachment is do less is more, because everything you try to do less in retinal detachment, they can get much better in function and visual acuity. But congratulations, beautiful case, very nice to see you. Thank you. Gracias.
Thank you, Jorge. It's nice to see you again. Thank you for all the comments.
Thanks a lot, Olivia. And is Andreas de Luciano?
Hudson, your voice is very distant. At some points it was very good, but now it's distant.
Yeah, I agree.
Hudson, Andreas is trying to enter, but he can't. Can you help us with that matter, please?
Okay, no problem. So we move on to the session now. And as I said, sometimes we have to mix the presentations due to the areas that you live. And of course, we feel everybody in the same house right now. It's very honorable for us to be all together, sharing different cultures, but sharing different cases and sharing different results, but always learning with each other. And I would like to invite, as a keynote speaker for the Middle East societies, Dr. Adel Al-Akili, that I had the pleasure to meet back in Saudi Arabia in the last Saudi Retina meeting. Thanks, Adel, for participating with us. Thanks for honoring us with your presence.
Thank you very much for having me. I'm very pleased and honored to be with you guys today. I'm not sure if my voice is clear or not, but if it's possible, can I share my presentation?
Yeah, if you could share. You actually, I did not get your email.
Okay, I can share from my side.
Oh yeah, oh sure, that's fine. That's fine.
Awesome.
I like the colors behind you, the colors from your country.
So yeah, so just briefly about me, I'm based in Riyadh. I'm basically working here in private practice in Maghrabi Center. And again, I was very honored to meet you, Hudson, back in when you came to Saudi Arabia this year. So it's definitely an honor to share my case with you guys. So without any further ado, I might start the case now. I can hear some voice in the background. If anyone here?
I see the slides, but they are not moving yet.
Okay, so this is a 22-year-old lady. She's a known case of retinoblastoma. She was unfortunate to have one of her eyes inoculated because of the advanced disease. That eye, the good eye, she actually received multiple sessions of brachytherapy, which was very thankfully successful in treating that disease. She eventually developed cataract, and she had phacoemulsification done when she was 10 years old. And through the follow-up, she was noticed to have posterior capsular opacity. However, she came complaining of a drop in her vision with low IOP, and this with a hazy view to the retina, we can say that she most likely had a retinal detachment. We also did a B-scan that confirmed the findings, so we were forced to go in to this eye and operate. So given that she had a band keratopathy, we needed to treat the cornea with chelating agent, and then went in and cleared that posterior capsular opacity. After we started seeing the eye clearer, we discovered that there was a membrane in the anterior chamber, so we had to remove that membrane as well and place the iris hook to dilate the pupil. I can say that generally this eye, because of the multiple treatment and surgeries, she had a very sick corneal surface. But we were lucky enough to actually be able to operate. And going into the eye, we can see the treated lesions in the periphery, and we can appreciate that there was a shallow retinal detachment. The trick was because of those abnormal and atrophic retinal lesions, we could not really very well delineate the break. So we had a very tough time actually going into that eye and looking hardly into the periphery, trying to find that break. We used triamcinolone to make sure that we remove all the hyaloid, and basically looking if there's any residual posterior hyaloid that we can peel off. We can see that at the mid-periphery there was this hyaloidal, this fibrotic hyaloid So we went in also, and just to make sure that we see clearly, we injected membrane blue, dual membrane blue. So just to make sure that we don't miss any high load that was there. And eventually we could find that she had a peripheral break at the temporal retina. And shaving around it, we could eventually free up this fibrotic hyaloid, and we actually demarcated that break. Again, we ended up with a very adherent fibrotic hyaloid just anterior to it, and using our forceps, we gradually could peel it off and then shave it using the cutter. Definitely, these eyes do not behave like regular eyes because of that heavy treatment. We know that when in the cases of a diabetic retinopathy, when we go in and try to peel the hyaloid off an area of a PRP, it can be challenging. This is actually even more exacerbated in this case. But eventually, we could free up the hyaloid. Just to make sure that I don't leave any fluid, I'm not very sure about the behavior of such an eye. I injected perfluorocarbon, milked that fluid out, and then eventually did 360 laser all around the edges of the normal retina and around the break. And we could eventually, I might skip here, and I injected silicone oil. This was an only eye, a patient with a very special situation that I did not want to leave the eye under gas, where I'm not very sure what's going to happen. And thankfully, at the end of the surgery, the retina was flat. But you can appreciate how it was a very difficult eye to deal with because of that sick, the sick ocular surface. And because of the multiple treatment, there was also a lot of adhesions and some sort of symblepharon. In the post-operative period, the patient showed good visual recovery, and we kept following her up until eventually she developed a cystoid macular edema. Of course, given that we looked very carefully, I was sure that this is not because of an epiretinal membrane, but rather maybe something related to the silicone oil itself. So eventually we went in and removed the silicone oil. But because of that sick eye behavior, as soon as we removed the oil, she developed hyphema. And with that hyphema, she had some development of anterior chamber membranes, and we had to inject anti-VEGF to help decrease the blood. Eventually, we discovered that there was neovascularization of the iris as well. And to remove that membrane, we also injected TPA. However, this problem kept on recurring. She flattened, she was in terms of the retina, but she kept on having those membranes. And with that severe limbal deficiency, she actually developed a persistent ocular defect. And we had to go in, our cornea colleagues had to do multiple procedures just to control her corneal condition. But this was bound to happen. She eventually started to have a very sick cornea, corneal scar, neovascularization growing into the eye. She started to develop low pressure inside the eye, and the vision became hand motion. I forget to mention that we actually had to go in and remove the IOL, remove some of that membranes. So we ended up with this situation where we have an eye that's going into phthisis, despite that the retina appears to be flat on B scan. So generally, these are challenging cases where you want to do the best for the patient, and because of that progressing hypotony she was in, we decided to go with our with our corneal colleagues and perform Boston keratoprosthesis in that eye. So at the beginning of the surgery, we placed our trocars and then they took over. They removed the corneal tissue, and you can see how there's a lot of membranes and developing in the anterior chamber. It was very challenging to remove this cornea from just to begin the surgery. you can see that the surface is very small. So we also had the difficulty of choosing a temporary keratoprosthesis that will help maintain the surface of that eye. But eventually we could place the temporary prosthesis and started the case. But again, an eye that is going into phthisis can be a little bit difficult to deal with. So we had to put that a ring and to maintain our the formation of the eye, and gradually try to do like an open sky where we try to peel the membrane that was forming in the anterior chamber gradually. It was definitely a very thick and adherent and can be very challenging to actually deal with. But with a lot of time and patience, we could gradually peel it off, and then we placed back the temporary prosthesis and carry on with the procedure. Thankfully, we could remove those membranes using the cutters, and eventually looked at the back of the eye, which was thankfully flat. But you can see those membranes that are developing on top of the retina, and can be really tricky to whether these are actually PVR membranes that are going on the retina, or these are just coming from the front of the eye to the back. And eventually we can find that the retina was not detached, and there was no membranes on top of the retina itself, but these are mostly ingrowth from the anterior chamber. And at the end of the surgery, because we know this is a case that is prone to go into hypotony, we decided actually to inject silicone oil and eventually place the Boston keratoprosthesis. And the patient at the end of the surgery seems to be, she did very well, and we're keeping her now with the keratoprosthesis and silicone oil. Pressure is maintained, and the eye is quiet, and we keep on following her, and she's been doing fine for the last 2 years so far with that situation. Thank you very much for the opportunity.
These are the colors of Saudi Arabia. A very beautiful, beautiful case. And congratulations, Adele, for your case. If you want to unshare your video now, please. I would like to...
yeah, I can stop sharing it. What?
To ask you to discuss on that case, and here Dr. King, would you like to comment on this interesting case from Adele?
Well, this is very challenging. I never did retinal surgery on the previous history of retinoblastoma. So what do you think the membrane, what is the membrane? Is it the residual hyaloid or PVR?
I think that this is basically some sort of epithelial downgrowth coming from the cornea with the multiple procedure that she had, or maybe it's some sort of like an anterior PVR rather than a typical PVR on the retina. Because going into the back of the eye, we can see that the retina seems to be flat, and there is no growth on top of that retina.
Okay.
Good decision was
to I did a very difficult case. You did fantastic.
Oh yeah, go ahead. Ahmed, I was just telling that a good decision was to leave the eye with silicone oil because of avoiding hypotony and other.
So there's a nice series coming from Bascom Palmer about multiple cases of hypotony that with sick corneas that they would actually implant Boston keratoprosthesis and keep silicone inside the eye. The tricky part is dealing with our glaucoma colleagues because they're not very happy not knowing the pressure inside the eye and how to estimate it. So it can be a very tricky situation, and you can't really put a tube inside the eye because it's filled with silicone oil as well. So this is our struggle. They're helping us out checking the pressure manually and estimating it. So she's on full topical. This is the only thing that I can say that's helpful in this situation.
Adam and Hudson, I have a comment about oil and hypotony, if I may. Are we okay with time? Or?
Sure.
Yeah, I think one thing I really think of, I think oil does not correct hypotony. And what happens, I think if you have a situation where silicone oil is in the eye and the eye is hypotenuse, yes, definitely I would not remove the oil. But I would not put oil to correct hypotony, because what happens, that oil does not stay at the back of the eye, it will move to the front. I mean, definitely more if you have a Boston keratotic creases and there's nothing, especially if the eyes are fake. But even if the eye is, even if there's a good peripheral iodectomy, because there's no aqueous secreted, it will move to the front, and usually it does not correct the pressure.
Ahmed, would you put
putting oil in hypotenuse eye to correct the hypotony? Because in my experience and my understanding, it does not correct it, and also you have the oil in the front of the eye.
Yeah. Would you put gas inside instead? Would you inject intraocular gas like SF6 or C3F8?
Yeah, I would. I mean, I try to avoid oil as much as I can. So I know single-eyed can be tricky. I would still use gas, but I think my comment was only like on the point of the hypotony. I think hypotony is the end of the game, unfortunately, and I don't see anything so far that corrects hypotony. I mean, I think early on you can peel a cyclitic membrane, but usually nothing works, and I think it's unfortunately the end of the game.
Oh yeah, before I ask Tarajan Skivas, you were trying to tell something?
I wanted to ask Adele, what is your plan for the future for this patient? How long do you keep the Boston keratoprosthesis?
I would say in this kind of situation, till a better solution comes out.
Okay.
Because definitely PKP in her situation is not gonna help. Hopefully, I don't know about the newer synthetic corneas that are out there. Maybe it's gonna be a better solution. But definitely, one of the things that was discussed was that she would have like a limbal cell transplant from the conjunctiva of the other eye. However, this is an eye that was also treated previously with brachytherapy before it was enucleated, so it was not a possibility. A living donor was a possibility. But again, the eye is not in a situation where it's just the cornea problem. It's the retina. This most likely is some sort of epithelial downgrowth that she's having. So I think until a better solution comes out, maybe doing something else.
Adel, I would like to add something. It's been a long time since I've seen a pole-to-pole surgery, and I never give up surgery like you did. This is an I never give up surgery. And there are two people that they promoted that. That was the late Forlini, Cesare Forlini, who had a session of pole-to-pole surgery and never give up surgery. It reminds me a lot of that. And that gives us hope that you never stop. You never give up. This is the extremely. Every time you show a section, I said to myself, now that's the end. And another section, now that's the end. Now that's the end. So you never give up. I really appreciated your work that you're doing and the stamina you're showing and the expenses you're doing and the patience of the patient. The patient is accepting every option you give him. And this is a lot of trust between the patient and you. These are very important points. It's not a technique only that you are mastering it. It's the way that you treat the patient. And never give up session should be done. And also for silicone oil, we have to find a study that would say in which cases and what kind of silicone oil has to stay there for a much longer time. And I got a place for that. And I say when we have emulsification or we have problems with silicone oil, there are cases that I exchange silicone oil to silicone oil because the eye doesn't accept to stay, like in trauma cases, like in these cases, without. And it doesn't have to do that you remove the eye, remove the silicone oil, and all these things happened. It says that it's better to leave it there for one-eye patients as long as possible. And it's just a macular little problem. It wouldn't solve the problem. But congratulations again. I think this is the top of what I saw today. Thank you.
All right,
Thank you.
thanks.
This is very kind of you.
Thanks a lot, Adel.
I would add, if it's possible, these are patients that really were born with the problem, so they are so primed into understanding that the struggle is part of their life. They were born with this problem, so the way that she understands and behaves is very different than other patients. I would say that I actually admire that lady for the courage she has. I completely agree with the point you made. The patient is a very important part of the story here, and I mean, for God willing that she keeps her eye, inshallah, until she's 90 years old.
All right, thanks. And I would like to invite now Dr. Andreas de Luciano, directly from Chile, South America, our neighbor over here. And may Marcelo, would you like to introduce Dr. Andreas de Luciano for us?
Yes, Andreas is a very good friend of mine. We shared some study together in Peru. He's working a lot with Orbis, and he's a very good anterior segment and posterior surgeon. And he's very well known here in the young community. So, Andreas, you're very welcome.
Thank you so much, Marcelo. Thank you so much for the invitation. It's an honor to be here with you guys. So thanks again to Dr. Houston as well. So I don't know, Dr. Houston, there is any chance that you can play my video for me, because right now I have no access to my PC.
Sure, I have it.
Oh,
right.
thank you so much. Thank you so much,
I have
my
it
dearest.
right here. I'm gonna play it right now, and thanks for participating in our Retinawesome. It's our first time here of many, I'm sure, and I'm pleased to have you in Retinawesome. Thanks, Andreas. Can I play the video?
No, thanks to you. So why this case is challenge? So I think in this case in particular, we have a young female patient with diabetes type 1. He has a RDP in poor control. He has a diabetic tractional detachment, and also is her best eye. So the question is what we do or how we do this kind of vitrectomy in this kind of patient with one eye, young patient with a mixed diabetic tractional detachment. So I start doing always, I try to do phaco if it's possible. Then I start doing the vitrectomy. I'm trying to remove 360 degrees, all the tractions before going to do the membrectomy. I am trying to do it very carefully to avoid any iatrogenic retinectomy. As we know, this can happen very often. So I will show you, I do one soon. And try to do the segmentation using 25G vitrectomy. Sometimes when you are trying to pull the membranes in this part of the retina, you can see I did a retinectomy, iatrogenic retinectomy, that I will use afterwards to do the drain of the supraretinal fluid. I am using the EPLM forceps to remove the tractions. I always like to use some perfluor just to protect the macular area, and also that helps me a lot to do all the dissection of the membranes. And after that, using one of the iatrogenic retinectomy, I'm doing the subretinal fluid. I leave this patient. After this, I did 300 degrees photocoagulation, and I choose to leave this patient with silicone oil because It was her only eye, and she was super young. And I removed the silicone oil 3 months before. So that's the case.
Very nice made. Very nice made. These diabetic patients, they bleed a lot, and I like to use the perfluorocarbon liquids to sort of halt the hemorrhages, and that helps a lot.
Helps a lot.
I deal with increasing the bottle height, the intraocular pressure, the PFC, and I like using also endocautery. But your case became beautiful. Very good.
Thanks.
Congratulations. Anybody would like to comment on Dr. Andrea's case? Nice view. What system you use? Oh yes, Natarajan. Yeah.
Yeah, no, I'm not able to open my video. I think it says you can't start your video. So you would allow me, I think.
Oh, okay. Video.
No, my video. Like you can hear me, but you can't see me. So it says you can't start your video because the host has stopped it.
Okay, just a second.
Hi, Thanasis.
Hello there.
Hi.
Nice to see you. Were you in another meeting before?
That's right.
Natarajan, good to see you, my friend.
Hi, George. How are you?
Doing good.
Yeah. So, Dr. Andreas, excellent presentation. My case is also going to be similar because we are daily doing a lot of diabetic vitrectomies. So I think what you did was right, and keep the oil for some time, and I don't remove it quickly. And in case after removing all the fibrous tissue, I use anti-VEGF at the conclusion.
Yes. I use it 2 days before the surgery.
Oh, okay. So now you can see me.
Yeah. Hi.
Oh, I can see you now.
Yes.
So now it's okay, Natarajan?
Yeah, it's okay. Yes, it's okay.
Okay.
And,
Always sharp.
I guess we have, Natarajan, your case. If you want to present your case.
Use and abuse of silicone oil, and I think you are following it well. So you have to remove all the fibrous tissue and then make sure that you do the silicone oil.
In those tough cases, silicone oil sits very well on the retina. And usually the question, I don't know if you agree, Andreas, what do you prefer, the 1,000 or the 5,000 centi-stokes? And what makes you decide on which oil you use? Do you think it's a matter of PVR or contraction, or it's a matter of time, or how long you want to leave the silicone oil inside the eye?
Yeah, exactly. I think it is, the reason is, of course, multifactorial. In this case in particular, or at least always when I have a complex case, or sometimes when I'm not sure how the retina is going to behave, I'm trying to always use 1,000 cc silicone oil. That's at least what I use or try to use in these kind of cases. If I have a patient with a more complex, or there is any patient maybe that I cannot have a good follow-up, or with a lot of PVR, for example, I try to use 5,000 just because I will give the silicone oil more time inside the retina. But I always try to avoid silicone. But in this case, I use 1,000 cc silicone.
All right. Thanks a lot. Natarajan, do you have your video ready?
Yeah, ready. Sorry, I think suddenly the net failed and I had to use another Wi-Fi.
Good luck, my friend.
Hi, Andreas. Okay. So can I start, Hudson?
Sure. Go ahead.
Okay, I can share my screen. So you can see the screen?
Yeah.
So this was a patient with a cloudy vision since 5 days, diabetic of 26 years, insulin dependent, hypertension 1 year, and PRP was done 3 sittings, and then had a eccentrics, and then
Are you on PowerPoint presentation?
I have a PowerPoint. I don't know. I'm again opening it.
And thanks, Santarajan, for including me in the DARF program. We have these lectures every week. This
Yes.
Wednesday we could not participate because of, the country was busy here with the elections and complaints
Yes.
everywhere. So, but next Wednesday I'm there posted. I like the meeting.
Right. Yeah, I know. Thank you. So we have what Tanas says. Now I'm joined a group of hospitals and we are having every Wednesday evening a postgraduate or a fellow presenting on the cases.
Do you have another time limit in India, in your place, in your hospital? Do you have a 48 hours day? I'm sure you have you did some changes in the time limit. Put a few hours.
I know.
Oh, come on, don't pull our legs. I mean, I have to do this, and this. And then I go to the Facebook and I see that you are in 3 different countries the same week.
What's the why it's not opening? Oh God.
Slow down.
Yeah, I know.
I also want to congratulate Dr. Mahdi Al-Mubarak for his comments in the chat and for everybody to participate as well. We could go to the other presentation.
Yeah, okay. By the time I'll say, sorry, I don't know what happened suddenly. Yeah, okay, you go to the other one.
No problem. And now we are going to introduce from the BREVS, Brazilian Vitreal Retinal Society, our society back here in Brazil, our good friend Jorge Rocha to present his case. And Jorge Rocha always presents us with interesting meetings in the World Retina Congress. Thank you, Jorge Rocha, for participating. And the screen is yours.
Let me see here. Can you see my screen?
Yeah, very good.
The voice is okay?
Yeah.
Hudson, thank you very much to invite me for this distinguished group. So good friends. Many of them gonna meet at the Pan America 2 weeks from now, and others gonna meet in Pakistan in 1 month from now. Today we're gonna try to be fast because this is a part of big talk. News insight in PVR. PVR is something that's caused us a lot of trouble. 5 to 10% of redetachment is caused by PVR. It's not our fault. It's not because we miss a hole or because we did not laser well, just because PVR is something that's happened very frequently. And this is one bad case that we're gonna discuss you. Sometimes I think twice on such a bad case. But if the patients agree to do many surgeries or the possibility of total fail, I go ahead. And the first thing is try to pull all the membrane. I start for the posterior pole and try to peel as much as I can. Sometimes we can spend an hour trying to peel and peel. I use the PFO as a tool, and when I finish and see that the real cause of the detachment is the shortness of the retina, the best thing to do is to cut. But when you decide to cut, you have to really cut. It's something that is not be economic, not be something that's you do less. You have to cut every part that is shorting and make the retina not attached. And sometimes you have to cut 360, and also has to do some cuts in the retina just to make more flexible to reattach. And perfluorocarbon is something that we have to use, laser and oil. And try to keep this oil for a long time, not only for 6 months. Sometimes I keep for more than a year. And take it out all the anterior retina that can make fibrosis and detach the ciliary body and hypotony. But the other thing is the PVR causes trauma, uveitis, choroidal detachment, and it's a wound healing process. That's RPE gonna change, and the process that's caused he's become metaplasia and mesenchymal transition and become a kind of fibroblast. It's caused for 2 or 3 months, and to operate and remove all this membrane, it's the way to do. But many things was tried, steroid, fluocinolone, heparin, and now many people are trying methotrexate. That is a folic acid analog, antiproliferative, that's gonna inhibit the DNA synthesis. And we can use up to 400 microgram. That's many people use for uveitis or for lymphoma, intraocular lymphoma. And many papers, serious case, has shown very good results with use of methotrexate. And some advocate 100% reattachment. And there is a trial they call WARD that's are using for 16 weeks every week injection compared with sham. And I have some case. For now, I have 6 case. I use in methotrexate, and all the 6 case I use around 300 microgram inject every week for 2 months, and I got very good results. And just to open the discussion about treating PVR with some of adjunctive treatment, because it's something that's really caused us a lot of failures. Thank you.
Thank you. You are right. We have to deal with these. We cannot blame us, but you know, PVRs happen, and oftentimes they happen when we most do not expect. And I know that Marcelo Murilo Sassamoto has a very good experience on using methotrexate. He uses a lot, and if he cannot comment now, I don't think he is probably around, but could you comment, Ahmed, about the PVR? How do you deal with that? Do you like doing retinotomies 360, 180, 270? What are your thoughts on that? And when you get the PVR, what is your first approach? Ahmed, can you hear me? Yeah.
I'm here. I can hear you.
Yeah. Yeah, your first.
What's the question about methotrexate?
Yeah. About methotrexate.
Really, actually, interestingly, Georgie and I were speaking about this the other day in his very nice podcast. I don't have much experience. I've done few cases, and I really don't have a good feel to it. I've tried also 5FU in the past, and it didn't work in my hands. But the methotrexate, my experience in PVR is limited. I have good experience with methotrexate in lymphoma and uveitis, but not. And I think it's a rather safe drug. And if you avoid the drug leaking out on the sclera and the conch, and also look for maculopathy, I think it's a safe drug. But does it work or not? I really don't know.
All right, Dr. Esquivas, you have experience on those cases with PVR?
My question is, would you have any reasons to be concerned about systemic side effects? No.
Actually, no. Just because, as Ahmed said, we are using methotrexate for uveitis and lymphoma for a long time, and have very good papers proving that up to 400 micrograms is very safe. We don't have any issue, systemic issue about using methotrexate, intraocular methotrexate, and then we don't have this. The only thing that may happen is corneal epithelial defect that can happen, but in my 6 case, I haven't had anything.
Okay, thank you.
Well,
Dr. Kinley, do you want to ask?
well, we treated a lymphoma case with if we have received the injection of say that the cornea remained clear. If we make more frequent, like twice a week, then the cornea will there's a macular epitheliopathy. But we treat the patient with that will improve the cornea. So my question is, what's the dose of your methotrexate and how frequent will you inject after if the patient is filled with silicone oil?
I inject inside the silicone oil and inject every week for 2 months because we try to go through all the PVR cycle. The PVR starts with 1 month and the peak of the PVR cycle is 2 months. And then all the other papers said that's the only way to really prevent something is stop the metaplasia. That's mean the RPE gonna change in fibroblasts, and then this happened for over 2 months, and then I have to inject every week.
Oh yeah.
How is the dose stay with the patient without silicone oil? Dose. The dose
all the case that I did was bad case, and all these patients had already 1 or 2 surgeries previously, and I inject oil in all. I don't have any experience in inject outside oil in the cavity, but I think it's not a problem to inject because the dose that's gonna be between 200 and 400, it's gonna be the same, even with oil or no oil.
So you inject the methotrexate as long as the patient has the oil in the eye?
I waiting more than 2 months to remove the oil. I used to remove this oil for 6 months, but I inject for 2 months. The oil stay more than the treatment with methotrexate.
Would you consider injecting after you remove the oil to prevent a new PVR?
It's possible, but I never did that. Just because when I go to remove the oil, the eye was so stable that's not caused me any impression. I have some patients that I'm following for more than 2 years. They are attacked in a very stable way, no more PVR.
Okay.
But I really don't know. I'm anxious to see the trial that's running in US right now, that's the Guardian, and see what the result tells us, if this thing is just an impression or that's real fact.
Yeah, okay, thank you.
Okay. André Jucá?
Yeah, congratulations, Georgie. Very nice job. I have 2 questions for you. The first question is, which kind of patients did you choose to treat the PVR? Is the patients that already had the PVR, or is a population that is at high risk of developing PVR? And the second question is, do you inject the first injection is just after the surgery, or you wait a week to do that?
Very good question, my friend. All my patients had already at least 2 surgeries previously and with bad PVR. Was not a patient that just with high risk of PVR. I choose patient that had already the process. And I start the first inject at the end of the surgery. I just leave the patient with oil and methotrexate.
Okay, thank you very much, George, and nice job. Thank you.
Thank you. Sasamoto, I know you got good experience in methotrexate. Can you tell us a bit about your technique and dosing you use? And as Jorge Rocha answered, he waits a bit and prefers the patients that have already PVR. What about you? Do you do methotrexate as a preventative method, or you choose the patients that have already PVR to start the treatment?
When I use methotrexate, I use before and after the surgery. Actually, probably 2 weeks before or 1 week before I enter with the patient to the OR. And I use it for at least 6 months. In some patients, I try to extend for a year. It depends the case. So I think it's a new therapy that is being performed 3-4 years before, and it's bringing good results. So that's what the dose is 1,200 in the OR, and before is 400. Before surgery 400, intraoperatively 1,200, and then I go back to 400 again for at least 6 months. Every week I put the intravitreal injection, and I long at least for 6 months. It depends the case.
Yeah, good. So you use quite a high dose, and then you taper it down, and you go a little more up to 6 months. It's a good idea. You know, as Jorge Rocha said, we don't actually have a full answer on that, but studies are coming, and still PVR is our major enemy, but we're going to get over that.
There was a study on also performed in Germany, was called PREVENT study. Perhaps you heard of the study. It was just published, and it was injection between 5-fluorouracil and heparin, and it showed no difference in the amount of PVR. So it's a difficult topic.
Yeah, it is. Before we move forward now to it's going to be André Jucá's talk, but after André and before my talk, we could go with Natarajan in between if you have your slides ready.
I'm ready. I'm ready, Hudson. Can I present?
Sure, go ahead.
Okay. Thank you, Hudson, and thank you all for patiently listening. So you can see my slides now?
Yeah.
Okay. So this is a patient with a cloudy vision since 5 days, with diabetic 26 years, insulin dependent, hypertension since 1 year, and then I had a PRP in the past with also eccentric, that is the Lucentis injection in the past. So this was the pre-op diagram, proliferative diabetic retinopathy with the combined traction retinal detachment with rhegmatogenous element. The visual acuity was a hand motion, and I planned a 23 pass plane vitrectomy. I always have a beveled entry so that the sclerotomies are well closed even after removal. You can see the 3-port vitrectomy in progress. I'm releasing all the traction and trying to get an edge to go between the membrane, and then I want to make sure all vitreous is removed, so I'm using the steroids to stain the vitreous, and then I complete the vitrectomy so that that no vitreous is left behind, and then we can see the traction, if whatever is there can be released using the vitreous cutter. And since it's already a bullous detachment because of the rhegmatogenous element, in addition to the traction, it was a challenge. So I decided that I will use perfluorocarbon liquid to stabilize some part of retina. So that's what I'm doing now. And then I will lift the membrane and find the cleavage between the membrane. You can see the bullous was due to the recombinous element. So now I have a channel illumination, and then using the forceps and also using the curved scissors to sever the attachment between the membrane and the underlying retina. So make sure that it's like a total en masse removal of the entire membrane which are producing the traction. So you can see the whole thing has been removed as a sheet, and then the recombinous element is still, the break was very small, so fortunately the PFCL was holding the posterior retina, and I'm dissecting, and then I'm actually removing the whole mass with the vitreous cutter, removing it. In case you want to do a histopathology, you can do that. And this is the cut fibrous membrane. And I will go through the same break and do an endodrainage so that the retina can be attached, and then I do a PFCL silicone oil exchange, which you can see. This is a retinal brush going through the pre-existing retinal break in the. You can see some amount of blood came and also subretinal fluid, and then the PFCL was keeping the posterior pole, and then the endodrainage through the retinal brush helped to settle the retina, and then partially I fill the eye with the gas, and then I also remove the PFCL and use the oil. You can see some amount of pre-retinal hemorrhages left behind, but I try to remove the surface blood from using the retinal brush, and also now I'll use the silicone oil and do endolaser pan-retinal photocoagulation, as well as around the retinal break which was there. And sometimes I give 0.1, this is a break which was there while we're removing the membrane, which has been now well covered with the laser photocoagulation. And this is another break on the nasal side. So along with the PRP, all the breaks are covered, and you can see multiple. I had a twin light, that means 2 light pipes to illuminate, and then removed all, and you'll see the postoperative picture. This was the fundus picture. The visual improved from hand motion to 636 with the silicone oil, and some fibrous tissue in the periphery, but the optic disc is slightly pale, but retina is attached well. And as earlier Andreas mentioned, leave the oil for some time so that may continue monitoring the intraocular pressure and make sure the eye remains quiet.
Beautiful, beautiful case. Diabetics are always not easy. And I've got a couple of cases that we call these crunch diabetic retinopathy with complications, and after injections, after anti-angiogenics, they don't become stable. Actually, they get worse. And so these are the fast cases we have to go on and operate. So I would like comments from Ahmed. Could you comment on these diabetics?
Pardon?
Could you comment on Natarajan's case?
Yeah, no, I think it's a beautiful case. It's a really difficult case. Diabetics are really difficult. No, I like the bimanual dissection. I think one thing I just do differently, I try to avoid oil in diabetics, and even single-eye patients, I still use GANs. I think the oil, you get pre-retinal membranes, and I think the quality of the vision with gas tends to be better. So I tell patients, even like single-eye patients, that you will need help for a few weeks after the surgery, and that we're going to use gas. But no, it's a fantastic dissection, a beautiful case.
Thanks, Jorge Rocha.
Hudson.
Yes. Terrific case. Congratulations. Your hand's easy, but for anyone to operate such a difficult case is something a challenge. And another challenge, as Atanasio said, you can go for different meetings at the same time. It's a mystery of life. Only you can do that. Nobody else. But anyway, just discussing about your beautiful case, have to tell that when you operate some bad case, and we have to learn with the membranes, have to feel the membranes, have to touch and see how you can pull, what you can cut. These things come with time, but it's something that we need to see and listen all the tissue. And I agree with Ahmed that we should not, we have to avoid oil. I use air and gas most of the time with diabetics, and each time you make a hole is a fail. We have to avoid any hole in diabetic. We should not make retinectomy, because if you have fluids, leave there. The RP gonna pump this fluid is much better, because you never know after you make a hole and laser what's gonna happen. Diabetic is a big box of different tricks, and it's not easy. Congratulations, beautiful case, very tough case.
Thank you.
Sasamoto, would you like to comment?
Just want to comment. Sometimes what happened to me when I use gas is bleeding can occur, no? Afterwards the gas, so that's sometimes is an obstacle with this type of patient and using gas.
Yes, that's I agree. I think each one has to introspect, and that's why I quote the Surgical Self-Education by Steve Charles, and I've also written in my new book where you have to assess and what's good in your hands and what's good in your protocol for the patient, and based on your like experience and also the various others' experiences.
Yeah, one nice tip: if you get blood and in front of the macula, and with silicone oil, you can inject TPA to liquefy it, and it drops down. It's a nice trick.
Good idea. Yes.
André Jucá?
Congratulations, Natasha. Wonderful
Thank
case.
you. Thank you, Andrea.
André, table is yours. And if you want to show your video, or if you want me to present it for you, just as your choice. Do you want me to display the video? Are you okay? We are already sharing. All right? Can you hear, André? André, we cannot hear you. I think your sound is off.
Okay, sorry about that. Let me try again. Can you hear me?
Yeah, now we can hear you.
Okay. Okay. This is it. Okay. I would like to thank you all for this participating in this nice meeting. I have learned a lot today. And I just brought this case of acquired bullous retinoschisis. This patient is a 65-year-old patient, a pseudophakic, with a reticular bullous retinoschisis that was threatening the macula. The patient had cellophane maculopathy, but the visual acuity was not too bad. He had 24 visual acuity, although he had this complaining of losing his scotoma. And this is the aspect of this very bullous retinoschisis and the cellophane maculopathy. So we decided to perform surgery because the patient was very symptomatic. And we did also this OCT. And as you see, there is this membrane. And also the splitting that you see is more at the level of ganglion cell layer than at the level of outer plexiform layer, as most traditional retinoschisis are. This kind of retinoschisis at this level can be very bullous, as we know. And these pseudophakic patients, we decided to perform vitrectomy to solve the problem. And here you have this very, very bullous retinoschisis, and you see the macula. And this was shading already the macula. You see it's very thin wall. And now we created a DPV, and then the patient got, you are going to see right now over here, a detachment. So we have now on live what we call the ischiosis detachment. So only ischiosis was present, but I think a small hole in the wall make this become ischiosis detachment. That's a condition that we all now and then face. So we decided to remove this thin membrane after using this brilliant blue dye, and then we inject perfluorocarbon, but the fluid didn't really go away. So we decided to perform a hole in the inner wall of the retina and remove all the fluid attaching the scases. And then we go on and try to remove as much as vitreous as we can. We know that retinoschisis sometimes evolve to very hard cases of PVR. So we did an air fluid exchange, and we did all the laser in the periphery. Maybe it was a little overtreat, but we didn't want to miss any small break. And we did decide to perform laser on the schisis area, since this area was already dead, and we have an absolute scotoma on the schisis region, as we know. So we did that, and we did also the 360-degree laser, and we just left with SF6. We did perform this SF with non-expensive concentration. And here you got this nice scar. But look at the OCT. The schisis is not present anymore. But we can see that the temporal retina is there is a thinning of the temporal retina, and the ganglion cell layers is kind of atrophic. So we brought this case to show unusual case of schisis threatened macula, and we decided to operate it. Thank you.
Very cool and beautiful images. And schisis retinal detachment, you have to be aware of it. And the laser that you did is as a sort of barrier around the schisis area, and then it healed so well. The image got so good, and most important is that you don't see the schisis anymore. The post-operative OCT shows that clearly. Congratulations.
Andrea, you treated the patient very, very nice. Congratulations. But I would have a question. Would the localization of the break allow you to perform buckle?
Yeah, it was not a schisis detachment at first. It was just a schisis, so there was no break. You see?
Mm-hmm, mm-hmm.
During the surgery, that happens to become a schisis detachment, because we did... I didn't see it. I imagine I did a iatrogenic, very thin wall. It's just ganglion cell layer. We did perhaps, and then we got this schisis detachment during the procedure. But at first, the patient did not have a detachment, just a big schisis that was threatening the macula. So in schisis detachment, buccal is already an option, but in pseudophakic patients still. But anyway, some guys decided to put something to protect the retina. In this particular case, there was no detachment, just the schisis. Okay. We do perform in traditional retinal schisis, just laser to bury it, but it was too posterior and too bullous, and the patient was complaining, and there was also this membrane that we had to remove anyway.
Okay. Well done, Andre. Very nice.
So hey, I have a question. It's a beautiful case. Could you just have done like a retinotomy in the inner leaflet as you've done, and not laser the outer retina because there were no outer retinal breaks, or is it the case that there's definitely outer retinal breaks there?
Yeah. No, you know, we could maybe it was over-treated by laser, but in any case, this schisis retina is that retina. There is absolute scotoma. It's not like retinal detachment that you have a partial scotoma. This is out, it's dead retina. So we decided anyway, it's better to treat it. But it's my opinion. I don't know if everybody agree with that.
Well, I think you did a great job, but the punchline of what I see, what I can understand, is that the patient was complaining.
Yes.
The punchline. You can avoid, you can do something else, you can do something this, but if the patient is complaining, you have to do something, and you did a beautiful job, as usually.
Thank you very much, Athanasius.
Yeah, really beautiful case. And before we move forward, we have two more cases left. One is mine, and to wrap up the meeting is going to be the last one from Hamed. But I will show you my case just now. And it's interesting to show you this case and to try to provoke you on thoughts on what to do and why to do that. And I'm trying to save, you know, time maybe, because we have to think of PVR, we have to think of complications, we have to do it simple. This patient is a medical doctor, and he had a very good, interesting case. And he developed this retinal detachment while he was traveling in South America. He had this vitreous hemorrhage, and he was feeling the his vision was hazy, and then he was diagnosed there in another country in South America as a retinal detachment case, and then he rushed to our city for the emergency vitrectomy. Actually, he's a phakic patient.
This is inverted vitrectomy. Minimally invasive phakic macular on retinal detachment vitrectomy with endolaser and intraocular gas.
So we try to be minimally invasive.
The patient is phakic. I start here a core vitrectomy. There was a bit of a vitreous hemorrhage with some hazy media. Cortex cleavage must be performed. It is possible to see here a attached versus detached retinae. Trimming the vit base is a must, and of course watching the lens. The macula is pretty well attached. The temporal peripheral retinal detachment can be noticed, and the retina is quite mobile. A horseshoe tear is found, and I hold the cutter steel right next to it. the cutter opening facing me. Vitreous attachments should be removed thoroughly. I turn cutter now facing the retina. See that I'm draining subretinal fluid through the hole. It is time now for a T-shaped retinotomy, very focused, so as to help in the drainage process and remove additional subretinal fluid.
That was the source of the vitreous hemorrhage.
I like to observe the macula after these steps to make sure it is not involved.
We have to watch the lens all times. See, now retina is all flattened. And this is a minimal T-shaped retinotomy at the very periphery.
The area is pretty well attached. I like injecting perfluorocarbon PFC to make sure retina will stay attached and stable.
We're going to protect the macula here, otherwise it could detach. And remember, it's a MAC-on retinal detachment.
Endolaser has a very good uptake now with PFC, and I do it peripherally as well. Of course, the lens should be watched at all times, and the eye should be turned towards the direction of the cutter, so you move the lens away from its shaft. In-air fluid exchange is now performed.
I start AFX near the hole.
I now remove PFC with a backflash cannula, and you should go after the last droplets at the most dependent position. If you think it's necessary, you may use a macular lens for that reason.
So removing the PFC from the hole at the periphery avoids you from getting subretinal fluid. I like using the MAC lens so that you get the less droplet.
And that's it. I appreciate your attention.
Yeah, it's interesting case that I showed you to show that there is not, in the, we usually do whatever has to be done. We had the teaching from the past that, and from ours as well, that the phakic you should do buccal, the pseudophakic you should do vitrectomy. We even did some papers in Toronto, Canada with Dr. Deveni and Dr. Lam that wide-angle vitrectomy viewing systems and doing sclerobuccal combined with vitrectomy for pseudophakic retinal detachments. But in some cases, you gotta be minimal. You gotta avoid inflammation, you gotta avoid too much of actions. And this case went so well with no PVR, no other problems, and we went straight to the hole and drained the subretinal fluid, did the laser. The patient got phakic all the time, and it was easy to do that, easier, and that's what I call the minimally invasive. André, would you like to comment on this case?
Yeah, congratulations, Hudson. It's a very nice case. I believe that surgery, we should do less is more. And you were perfect. I think there is some factors that increase risk of PVR. And if you do less, you have less inflammation and less risk of PVR. And it was really very nice case, and well done, my friend.
Yeah, and when I say less, is that of course we can do less, but we cannot forget to trim the vitreous base, for example. And in such phakic patients, and people do not usually go so peripheral because of constraints and afraid of getting the retina and also the lens. So when I do the peripheral vitrectomy in a phakic patient, I move the eye towards the direction I want to go with the shaft of the cutter below the lens. And the most, you have the lens here, the most perpendicular you are with the cutter from the lens is better, because if you start to go parallel like that, going down, and then you touch the lens. And so the best way to avoid touching the lens is to move the eye with you and with your instruments. And thus you avoid in this way touching the equator of the lens and go straight to wherever you need to go and perform the surgery. In these cases, since there is no PVR, it went very well with only air. I did not put much gas. I mean, not gas, not air gas. I put SF6, a non-expensive one. It lasted there for 15 days, and that was about it.
Yeah, congratulations, great case.
Thanks a lot. And anybody wants to comment? Athanasius would like to comment on my case, please. You are the professor.
Let me comment. I picked up the point. It's simple and beautiful, like whatever you're producing. But the issue that you left it aside, and it has to be discussed a lot, is in phakic patient how to preserve the lens. And there's a lot of tips and tricks how to do vitrectomy, because trying to do a fluid exchange, try to do something, you accidentally touching the lens, and then you are in trouble. So we should make a session of how to do vitrectomy in a phakic eye, avoiding the lens. It's a simple thing that people think it's simple, but if it happens to me after 30 years of vitrectomy, it would happen to everybody also. So you gave us a clue of how to save the lens,
Yeah,
but
I
needs a lot more.
I always tell the fellow that is with me in those cases, the reason, because the fellow and the assistant, they are giving me instruments, and the fellow as well, but when it's a phakic patient, you got to be very careful with the lens, and I watch the lens all time. And the trick, the good tip for that too, to avoid touching the lens, is to move the eye straight where you go at the same time, because sometimes you have an assistant and you go up and the assistant delays and takes a while to go in the same direction. And so that's the time when you are already there, the assistant did not move the lens, and then you touched the lens. I mean,
That's
the
what I
assistant did
mean,
not
but
move.
it's a lot more to that. A lot more to that. For example, scleral depression in a eye like that. Doing scleral depression, you just mobilize the infusion line.
Yeah, I know.
Second thing is how you keep the infusion line away from the lens all the time during your surgery. And the other thing that I do, I always change hands. When I want to cut something, I go left with my vitrectomy probe, and then I go right with the vitrectomy probe in order to avoid the curvature of the back of the lens. So this exchange of hands should be, and sometimes those three tips, for example, infusion line, exchanging of hands, and your tip should be getting together in a presentation to organize that. Let's go back to simple things that they produce problems to us.
Yeah, that's true. And as you are mentioning, I also switch hands. And the good thing is that you have here the lens, and you have here the cutter. If you go straight, if the break is temporal, so you are far from the lens. If it's nasal, So you might touch the lens. For that situation, I move the eye like that. So by moving the eye, you go below, far below the lens, and near the retina, and far below the lens, and you never touch it. And at the end of the case, you see the lens is pretty clear. And I like to teach the residents and fellows that a lot. But the reason that I do that alone, because I operate inverted. So I go to the right direction. When you have the inverter on, as most do, it's difficult to do that because you are going one way and the inverter is showing you the other way. So the reason why I operate inverted is also because of that, because I don't touch the lens and I can move my eye the way I'm looking, and the way I'm seeing the eye is the way that the eye is drawn. So, of course, I think we need a course on that, to tips and tricks and on doing that, and that helps a lot. And I try to avoid touching the lens as much as possible. And thank you for the comments. And last but not least, on our big list here is our good friend Ahmed Salam, that I met in Saudi Arabia. And Ahmed presented many cases there, and all cases were interesting. And he said, "Do you want just me to present one case? Do I have to choose a good case?" No, I said, "You have all your cases are just perfect. You go ahead, Ahmed, and present your case." And thank you again for participating with us in this. As Nathanael suggested, this is the first World Retinawesome event.
Well, Ahmed, sorry, I have to cut in. You are the sweet after the dinner.
Well, thank you so much.
At the end, keeping you at the end, knowing how nice what you're doing and really enjoy your company, I think we should put you always at the end.
Oh, thank you so much. That's very kind of you, very sweet. So I really appreciate the opportunity, and thank you, Hudson, so much as well for your kind words. Let me start by sharing. I want to show something, because I'm interested really in the basic vitrectomy and teaching residents like you and Thanasius and others. So I want to show you something about crossing, a diagram that I put together, which I hope that people following us would like, because it gives you an idea of how to cross the instrument. Then I go quickly into my cases. So here, this is the diagram. So if you look here, can you see the diagram?
Yeah, sure. Perfect.
Yes, so here, this is like the active hand. So it tells you really how to cross. So superiorly, you can cross until, this is talking about straight instruments in phakic patients. You can cross more with curved instruments like laser. But here, the endpoint is shaking hand. This is the surgeon view. So the surgeon is here, is shaking hand with the other port. Down, you can keep reaching down until a point which is like joining the 12 o'clock fovea and 6 o'clock. So you should not cross more than this. In between, you can cross till the equator, but you should not cross more peripheral. So that leaves you a little bit of the vitreous here, this area here, that you have to take with the other hand. And if you do this, you should not hit the lens. And yeah, it's just a simple way for to explain it for residents and fellow. So I'll move out from here unless you have any question. But these are the land points to my case. Now, I'll just share my other video. Okay, here's the other video. Okay, this is a patient in his late 30s with PDR and TRD and vitreous hemorrhage and type 1 diabetes. So the fellow was doing this case, and here we're starting by, we do that, we start on the disc, and then we feel we're in business and go in, out, and a bit of peeling up, and then after that dissection with the cutter. And the view is gonna get better here after the fellow controls the view a little bit better. Right, now the view is better, and you can see here the dissection. Sorry for the noise. And then staining with the hyaloid at this stage is nice because you can see the vitreous crisis, which is you can now tackle since you're already in a clean area over the posterior fold. I apologize for the noise. I'm in Egypt and outside the house.
Do you stain?
And further dissection here. And here's the point. Here's interoperative OCT showing that appearance. So the question is, would you peel the ILM or leave alone? So Hudson, can I ask you just maybe to keep the case interesting, for example, would you peel the ILM or you would leave alone?
Yeah, I tend to peel, even though I don't have this OCT at the same time, but I tend to peel. And at this point, after I removed the vitreous, the vit base, and also the hyaloid, I like to do in a complete air-food exchange and stain with brilliant blue, and I tend to peel. Most of my cases I tend to peel. Okay, so really I think this the video may be not giving the case like it's justice, but this was a really actually difficult case, and 1 hour we were really nearly done with the case, and the fellow was doing it, and I told him, let's peel the ILM, and he said, look, it looks good, some wrinkling on the surface, let's just leave it. And I always tell him less is more, and he told me less is more. I said, no, I think there are folding, let's just peel it. So I prompted him to peel it, and here's what's happening. So it's still him operating. But his view was not to peel, just leave alone. Right, as you would expect, I mean, we tried to do actually a fovea sparing peel, because I don't like the appearance of the fovea diabetic patients when it's peeled. But as you would expect, it's all stuck down. And now we have a stretch tear that you've seen. So the question is what to do, and I tell him, okay, well, I think we should peel around it more. So I took over, it's me operating. And I peeled over around it, coming from around it. And then I lasered the periphery. And then the question is, at this stage, would you laser the tear or leave alone? Which is in the macular area. So this is the situation here. So maybe, Athanasius, would you laser that tear, which is superior to the macula, or you would leave?
In a diabetic, there are two issues I have to remember. That the vitreous attachment is completely different than the vitreous of the normal patient, which it's much stronger and it's in much different places. It's in that. And the second thing is, if I have any idea that there's a membrane pulling, any pulling in the area, I would do laser. Anyway.
No, we relax it completely. So we relax completely around it. This area, even the ILM was peel around it. And that's what happened. So, I mean, I told him, so his question was, shall we laser this macular area? I told him, look, posterior breaks, no traction, we don't laser, we just put gas. And we did. And this is here 2 weeks post-operative, and you can see there's a detachment there. So we waited 1 week more, tried to position, it didn't flatten, so I had to go drain from the break, which extended a little bit, and then I lasered and I put C3F8. I don't have the post-operative view, but the retina is flat now and the macula is flat. So, and I put C3F8 here in this case, and when the C3F8 went off, the macula is flat. I think my personal learning from this case reel is that we ended up in a good situation. Some stria on the surface, but his outer retina looked very nice. And I think I always say less is more, particularly in diabetics. If I go back, I would just leave alone. Or even I may try, but if I find it's stuck, I think we should have left alone. The second thing, which I did not expect to happen, and this is my first time, I had breaks in the posterior fold before, but if there's no traction, usually they don't detach. In the classic teaching, the retina is thick, no traction, just put gas and don't laser. this was an interesting case. I don't know why he's detached. But I think Thanasius is probably correct. In diabetics, maybe things different. I really don't know. So that's my case.
Beautiful, beautiful.
Ahmad, I don't think you made a bad call. I think you made the right call, but it was bad luck. But it was a good call to peel it.
Yeah.
It wasn't a wrong decision.
Yeah, there was traction. If there is traction, you have to peel. But I agree, in diabetic, you should not remove the internal limited membrane because it can cause atrophy. But as you have nicely shown on the OCT, there was, and we saw it with triamcinolone, there was traction, and this traction may, after the surgery, with time, increase and cause problems. So it was a nice call anyway. But you got to get in again. But people that use silicone all the time, they got to get in at least once more to remove it. So you're still okay.
I think judging just
I
to
have
be
a better
aware.
experience on that. I have a better experience also on that. And I try to think of myself. If I leave a little bit of stria there, and the patient next day is seeing comfortably what he wants to see after a vitrectomy that I did for a diabetic patient. Or if I do something and produces so many trouble that the patient would not be happy and had to do something else. So I choose to see less from the beginning and to be happy than getting for the best result. And you always know they say the worst thing is to make it better than you could do it. So I'm on the let it be side, especially for diabetics. I'm a no-touch syndrome I have in my hand, and I try to have the patient happy at the next day, which is very important. If I touch too much and I have a patient unhappy because I did something excessive, then I would prefer to do surgery for this membrane 2-3 years later. I wouldn't mind.
Totally agree. And I think even the fellow was telling me, we just leave it. We usually leave it because, and I said, no, there's traction, let's be it. I totally agree. I think we should treat the pathology of today. Less is more. Keep life simple, and just really keep
all
going
the way
this
with
way. Yes.
That's what happened usually. As long as we doing surgery, you realize that as time passes, one realizes that less is more. It's totally true.
But still, Emma, thank you for showing the case so that we learned that in case in future we are tempted to do aggressive peeling, I think we should stop the temptation and leave it at it. I think that's a great learning. And it was nice of you to show that what you did. Nice.
Very nice, Ahmed. I have to show you later. I have a video when I get the ILM and remove it, the retina sort of flattens like that. So when you see those wrinkling, I don't think of atrophy. I think it's so superficial, mostly superficial, the surface retinopathy in that case, even though the patient is diabetic, that if you see the wrinkles and if they stain well, and when I remove, of course the retina get flattened. I don't usually wait too much. And of course, some patients don't have that indication, especially if they are ischemic. You could worsen and make the eye, the retina atrophic at that site. But usually that's not what that happens, at least in my experience. And you showed beautiful, beautiful cases in the case, and I think that's the matter of maybe a hole or tear. It could be also added to maybe the not very good outcome in some cases because of ischemia, because of the diabetic retinopathy itself.
Agree.
And thanks a lot. Thank you, everybody. We are now exactly 3 hours meeting. We went a little forward, but it was cool because I'm sure that always We always learn with everybody, and I also want to thank again for everybody for presenting, and just remembering that Ahmed Salam was the keynote speaker for the Society of Americas. Thank you, Ahmed, again.
So much.
And thank you from north to south, from west to east. Thank you, Olivia, for participating with us the first time from the representing the Latin Vitreoretinal Societies. And I appreciate Christos and everybody that spoke. I know it's a little bit late for you, for Natarajan, for Adele, but
it stays late at night.
I feel that the meeting was just perfect, Athanasios. And
I think this is the first World Retinawesome meeting.
Yes, we're gonna adopt this meeting, Natarajan,
with all the societies.
From this time, is the Vitreoretinal Society, but first it's a World Retinawesome meeting because it was very widespread. Thanks a lot, everybody.
And also, I would like to thank you for letting me getting to know Christos. Imagine that we are colleagues with the same Greek area, and I haven't seen Christos for many years, and I saw him by accident in Vienna. That means that we have a lot of Greeks in diaspora. We have a lot of Greeks outside that they are doing phenomenal things. And one of the tasks is that together with you, we'll try to gather them in Greece together to be on the side again.
A pleasure.
Next time, we would like you to join us in Greece, and don't stay in Hamburg very well comfortably, but with a bike and go around. Come to see the congestion in Thessaloniki. That's another thing. You have to remember that.
Thank you very much. I won't miss it for world.
Okay. You're welcome.
Thanks a lot. So have a good weekend, everybody. Thanks, everybody.
Thank you.
And soon we'll be posting the video in the Retinawesome YouTube channel.
Thank
And
you.
also, I would like to say enjoy life, because Nataraja is going to go clubbing now. It's too late.
Yeah.
Yes.
Going,
It's a Saturday
a lot
night.
of exercise in order to be able to dance at night.
That's true.
Hollywood guy. Hollywood
Yeah.
is there. Enjoy, my friend, for all of us. You have
Thank
to
you.
enjoy for all of us.
Bye-bye.
Thank you.
Bye-bye,
Bye.
everybody.
Bye.
See you.
Bye. Thank you. Bye.
Bye.
Bye. Bye, Hudson. Great.
Bye. Thanks.
Bye, Marcelo. Great.
Buenas noches. Bye, Adele.
Hi, Marcelo. He went. Okay. Good. Thank you, Hudson.
My honor. Beautiful Mumbai behind you. Beautiful Mumbai.
Yes. I know. See, I've come to the restaurant now, going for dinner with the guys.
Yeah. Nice.
Yes.
Bye-bye.
So,
Bye, Adele.
bye. So you can see the greeting. You
Wow,
can see,
beautiful, beautiful place. Wow.
yeah, I come for a dinner now.
Wow, what a table. Show us this table, please, Nataraja.
Yes, yes.
Wow. Really nice.
Yes.
You have Taj Mahal behind you? The picture is Taj Mahal?
No. That is a building, one of the old building in Mumbai.
Ah, okay.
So this is the 5-star hotel I've come in.
All right.
That's the hotel.
Perfect.
So good.
See you, Natarajan.
See you. Bye.
Bye-bye.
Bye.